This is a case study of upper GIT bleeding, which is defined as bleeding proximal to the ligament of Treitz. Two 40-year-old patients arrive at casualty complaining of vomiting blood, called hematemesis. They may also have melena stool or even fresh bleeding per rectum. One has a peptic ulcer disease bleed and the other has a portal hypertensive bleed. How do you differentiate the two? If either is hypotensive or tachycardic, they must be put in a resuscitation bay with continuous monitoring of their vital signs. Supplemental oxygen must be applied. Wide-bore intravenous lines with Ringer's lactate solution must be placed. And 80 milligrams bolus of a proton pump inhibitor, such as protium, must be given. And a urine catheter should be placed to monitor urine output. A nasogastric tube should also be placed and aspirated with a catheter-tipped syringe looking for blood-stained fluid. In addition to the routine history, the following questions should specifically be asked in these patients' histories. 1. When did the bleeding start? This gives an idea of chronicity and also possible severity. 2. Has the patient ever had a similar episode before? What was the cause at that time? And how was it treated? This may give an indication of whether or not there was previous peptic ulcer disease bleeding or varices, and this presentation is most likely a rebleed. Has the patient been regularly taking any medications that may provoke a hemorrhage, such as non-steroidal anti-inflammatory drugs, anticoagulants, or antiplatelet aggregation inhibitors, such as aspirin? If yes, a peptic ulcer disease bleed is more likely. Have any prostheses been inserted that might bear a causal relationship to the hemorrhage? For example, has a patient recently had coronary artery stents placed for myocardial ischemia and placed onto platelet aggregation inhibitors such as aspirin to prevent them from thrombosing? Or has a patient had a cardiac valve replacement and is now on warfarin? Is there a history of esophageal reflux, as this may indicate peptic ulcer disease? Is there a history of liver disease or previous infection with either hepatitis B or C? Have there been complications following a previous bout of acute pancreatitis? All of these may indicate the presence of gastroesophageal varices. Questions that do not help differentiate the cause of upper GIT bleeding include the following. What was the volume of blood vomited? This is a subjective question. And also keep in mind that a few drops of blood can taint a bucket of water red. The stomach may have been full of juices or partially digested food, giving the false impression of a lot of blood. Peptic ulcer disease bleeds are arterial, and variceal bleeds are venous. However, both bleeds cannot be excluded by the volume of blood that was vomited, as both can bleed a lot, and both can also have blood clots in the vomitus. Furthermore, the color of the blood that was vomited does not help differentiate the two either. If the bleeding is brisk, both will be dark red, as both still come into contact with the acidic gastric juices which start hemolyzing the blood. The presence of pain, epigastric pain in other words, doesn't mean that there is peptic ulcer disease. Bleeding in the gastrointestinal tract is painless, so patients do not complain of pain either way. With clinical examination, look for signs of liver disease, such as jaundice, ascites, the presence of spider nevi, abdominal wall varices, and palmaroerythema, whether or not there's a liver flap or gynecomastia in men. Any of these may indicate the underlying presence of portal hypertension and varices. Do a rectal examination with the examination of stool for its color and consistency, looking for tarry stool or melena. Bright blood or hematochezia may indicate a colonic bleed, or it may also indicate a massive upper GIT bleed. For further information, listen to the second voice note. Once you have a history and clinical examination, you should have a good idea as to what the most likely source of bleeding is. If it is peptic ulcer disease, then continue with the PPI at 40 milligrams BD. If it's a variceal bleed, add a somatostatin analog such as octreotide and a broad-spectrum antibiotic such as co-amoxiclavulanic acid or augmentin to the PPI. We usually give 100 milligrams of octreotide as a stat bolus, followed by 50 milligrams hourly, as this is a vasoconstrictor in the splanchnic bed and thus decreases the amount of blood that is delivered into the portal system. Once stable, they need an endoscope. This is called a gastroduodenoscopy or a gastroscope for short. This is done to confirm the diagnosis and to treat the bleeding if it is still required. The initial lab tests at admission should also include a full blood count, specifically looking for the hemoglobin value and platelet count, an INR, electrolytes, and a urea and creatinine. Keep in mind, though, that if the bleed has been long enough, some of the blood will have been reabsorbed in the small bowel, and the urea will be falsely elevated. So this actually confirms the presence of a bleed and not necessarily that the patient is in acute renal dysfunction. One should also do a blood typing cross-match in case a transfusion is necessary. A very good test for variceal bleeding is to look at the platelet count. If it is less than 100, the patient most likely has portal hypertension with increased flow through the spleen, which fragments the platelets, thus causing thrombocytopenia. These patients should all be treated as if they have varices until they have a gastroscope, which shows another cause, and the treatment can then be changed. So in other words, these patients with a platelet count of less than 100 should all be started on the triple therapy. In other words, a PPI, somatostatin analog, and a broad-spectrum antibiotic. Once the diagnosis has been confirmed and the bleeding stopped, if peptic ulcer disease, we should then consider starting Helicobacter pylori eradication, which is done with amoxicillin and clarithromycin orally for 10 days, together with a proton pump inhibitor such as protium or Nexium for 1 month. If the use of NSAIDs is suspected as the cause, the patient must be counseled about NSAID use. The most common culprit here is the over-the-counter purchase of Grandpa. You must advise them to always use these medications after a meal. However, ideally, they should avoid them wherever possible and use other analgesics, such as paracetamol. If it is because of aspirin or other antiplatelet agents, the patient must be referred back to the cardiologist for reassessment of these. Often the cardiologist will change the medication, or even stop it if it's been used for long enough. If a variceal bleed is the cause of portal hypertension needs to be investigated. If the bleed is stopped, the octreotide can be stopped, and the patient is then started on a beta blocker, such as atenolol, and they need to use this for the rest of their life. Also, if we have a cause of the portal hypertension, such as hepatitis B causing liver cirrhosis, the hepatitis B should also be treated. This is the end of my upper GIT talk.